Alrighty, initial reactions from the participants. Stressful?
Well, this was confusing too. I'm sorry to stick you.
Yeah, no, I mean, that's a limitation, unfortunately, of the simulation. Sure. And I think every room is going to have this layout. This is going to be the pulse oximeter, and so these are your patient pulse ox. The one with the sticker is going to be your venous saturation. So we're monitoring continuous venous sats in these cases.
Okay. So it's on the venous.
It's on the venous.
The
line.
negative line. Okay.
On the access line.
The circuit check again was critical because it looked like that, and that line's a great trick that we did yesterday, and it was right after the X-ray session. Although we couldn't convince CT surgery to fix it.
You know, it's just a line for them.
But then you had data to say we know we have a problem
So
now.
Right.
You know.
So data changes already. Alrighty. You want to summarize the case for us in one line?
We have a patient who suffered a malposition of his line post a procedure.
With evidence of
Recirculation.
aggressive recirculation. Yeah. Good. Does everyone agree with that? Alright. This comes back to, so in terms of recognizing recirculation, and this is a very common phenomenon. I mean, we see this, it's a function of pump speed most frequently, as well as cannula position. And I mean, if you're running a sufficient RPM, you always have some element of recirculation. If you look at graphs of RPM versus percent recirculation, it goes up pretty quick. And at about 3 liters, you have some, at least 15–20% recirculation. It's very common. The question is whether it's clinically significant, and whether you have to intervene or not is a separate issue. But in terms of making this diagnosis, you walked into a room where a patient is becoming more hypoxic. And obviously doing a circuit check is the most urgent thing. But part of that circuit check, again, going back, is to look for that color change. And in this case, you guys did ask for color change. But then, and I said there wasn't a good color, there was not a good color change. Your non-asked-for consultant did ask a good question. What was your question?
Are they both bright or are they both dark?
Yeah.
It was a curiosity.
Good. So the last case was there was no color change, but they were both dark. And so we were worried about gas exchange in the oxygenator. If you have no color change, but this time both bright, then recirculation will move way up. And then you can go and find evidence that supports that diagnosis.
And you're always going to have those two saturations. And the way to look at that is, if both saturations are going up, your patient's getting better. Both saturations are going down, your patient's getting worse. But if your patient sat is falling and your pre-sat is rising, that is recirculation.
Yeah, the most immediate clue with the thing here, the venous sat started off at 65, which is sort of where you expect a central venous sat to be. Once that venous sat starts going up and the patient is becoming more hypoxic, it's one of two things: either recirculating or the patient is producing oxygen, and we do not produce oxygen. Right?
And
last night,
yeah,
huh?
yeah.
We don't photosynthesize.
We're not trees, yeah.
Not yet.
Was the pressure a disruptor when we were supposed to check the pressures on there?
Well, I was saying when you're trying to assess things and you're like, well, is it something wrong with the oxygenator? You can always check your pressures on your oxygenator. If they're getting farther and farther apart, it may be an oxygenator issue.
Okay.
But we knew it wasn't an oxygenator issue when you got your post-gas and you said, well, it's got a PO2 of 300 and something on the post-gas, so that shouldn't be a problem.
So in terms of the factors that affect recirculation, okay, great. Really three major considerations to keep in mind. So pump flow, and this is just a given. I mean, no matter what you do, if you increase pump RPM, you get recirculation, and there's nice graphs that kind of demonstrate this. And really, even if your catheter positions are far apart, even if you have the cannulation of VRV, so if your cannula, you're draining, the SVC, but your return is in the RV, where you think you wouldn't have any recirculation. Once you hit about 3.5 or 4 liters per minute, you do have recirculation. So it happens. Catheter position is a major issue. If you have a dual site cannulation, the closer the drainage and access are together, the higher the risk of recirculation. I actually found a very nice study in sheep where they did it at 3 different sites, and they proved that the closer they are together, the higher the recirculation. So three sheep were sacrificed to prove that. It seems intuitive, but we have proof.
Do you usually, I'm sorry, to
cannula, we put them on